Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for doctors in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today we're extremely lucky to have as a special guest with us Morag McDowell, the Health and Disability Commissioner. Welcome, Morag.
Thank you, Lucy.
We also have my colleagues, Dr. Sam King and Dr. Chow Yen Chen, who are both medical legal advisors at Medical Protection Society, and I'm Dr. Lucy Gibbard. So, the Health and Disability Commission, which we're going to call the HDC moving forward, which I'm sure is how everyone refers to it. To clinicians, it often feels like a policeman who's looking over our shoulder or an axe that's going to come down on us if we make a mistake. But today we're hoping to allow Morag to provide us with some perspective on that and maybe some context to help us understand how the HDC works and how we as clinicians can engage in the process so as to get the best outcomes both for ourselves and for our patients. So it's great to have you here, Morag. And I thought it would be nice if you could start by just telling us a little bit about yourself and your background and maybe how it was you came to be the Health and Disability Commissioner.
Thank you, Lucy, for the introduction, and it's a pleasure to be here. Thank you for the invitation. So I am a lawyer by profession. It would be fair to say that when I was doing my studies in my law degree, medical law was actually not a specialty at all within the context of the degree, but towards the end of my studies, there was the Cartwright inquiry, and I do have a memory of that being beamed into our lounges through television. That piqued my interest, along with the fact that I had many friends who were med students who were having to do their first rotations at National Women's Hospital and some of the impacts for them then. There were also a number of events in the early 90s which really interested me as a young lawyer. So I went ahead and did my master's degree with a focus on healthcare law. And I was really lucky after that to have a number of different roles or jobs where I was able to work in a medico-legal practice, essentially. Be that when I was prosecuting and being part of a health law team, but also doing prosecutions, for example, under the Medicines Act, but also a stint as Director of Proceedings for the Health and Disability Commissioner's Office back in the early 2000s. My job before becoming Commissioner was as a coroner. So I was based in Auckland where there were a lot of hospital deaths. So again, lots of interface with doctors and medical professionals and other health professionals. And really, I've just been so passionate about the area. I'm also very passionate about people's rights. And I've also felt most comfortable in my career when I'm in the public service because I see tremendous opportunity and privilege actually in looking to see how you can make the system work better for people. So it just seemed like a natural fit when the job came up, and I feel absolutely privileged to be doing it.
That's awesome. It's interesting having that coroner background with it because it gives you a really good breadth of having seen a lot of medical issues. I wonder how much medicine you know these days. and how much of the acronyms, the three-letter acronyms, you actually know like a doctor would.
Well, over many decades, I've had the opportunity to read clinical notes.
Yes.
I have, as a coroner, I was in the coronial service at a time where we had lots of interaction with doctors when it came to, for example, the reporting of deaths.
Yeah.
And so having that direct conversation. So, yes, I feel like through the process of osmosis, I've learned quite a lot about medicine.
It would be interesting if you sat in the medical school exams. Anyway.
I don't know how I'd go on things like physics, but there you go.
Anyway, yeah, so thanks for that. And it helps for us to know what that background is, because I think the HDC is often just it's a name and a scary thing, and we don't really know what's in it, you know? And interestingly, in one of our podcasts last year, we had a member talking about how scary New Zealand doctors and other clinicians find the HDC. He was actually an American, but his experience of the HDC process, he found it more challenging and distressing than in the US having a patient sue you, which I thought was really interesting because I've always considered that it's a relatively, not benign is not the right word, but it's a fair process and it's understandable. But obviously for clinicians out there, it's very scary. So with the aim of kind of increasing the transparency and helping clinicians understand that the HDC is not out to get them, can you talk to us about the process that the HDC goes through when you receive a complaint from a consumer?
Sure. I do want to start by acknowledging the stress that comes with receiving a complaint. I think it's a natural human reaction to feel stress, possibly feel defensive, feel anger, but also concerned and worried about your practice. I absolutely acknowledge that it's not a pleasant thing, and that if the complaint gets escalated to HDC, there will be a process that doctors have to go through in order for the complaint to be resolved. But also I think that as a public-facing kind of role that doctors have, you have to expect that complaints are going to be part of your practicing life. I think the challenge actually for the profession and the health system generally is to manage those complaints as close as possible in time to the point at which they're being raised. And they may not be a complaint at that point. It might be an issue of concern. And as Commissioner, I have been strongly advising providers and provider groups, please look at your complaints processes, look at how you communicate with patients when they raise concerns with you. Because if you can resolve the issue then, it's the best outcome for everyone. It's best for the consumer, best for the provider. Most importantly too, it's important for any quality improvement measures that might flow from the issue that's been raised. And there's research to show that that's why consumers often raise concerns. They don't want what happened to them to happen to other people. So if you can show concrete action in response to the concerns that are raised, that will often meet the resolution needs of the consumers.
That's interesting. I actually very recently had a case where a clinician got a complaint and really did an amazing job of auditing all his practice, auditing his own practice, looked at all of that issue in depth, and the HDC said that's fine and closed the case before it had even. He had done a lot of work and had taken it very seriously and done everything he needs to do to make sure that was not going to be an issue of concern, and give credit to the HDC. It was less than a month and it was finished.
So, as I said, it would be fair to say that HDC has been very much focused on early resolution. In terms of process, obviously we get complaints every single day that come into our inbox, and we have a triage process. In the context of our own resource constraints, we've identified that we need to be very intentional at the front door of our process to make sure that our resources are being directed to those complaints that need HDC involvement. There's quite a lot of senior resource at that early point of triaging the complaints. And when I say triaging, what we're doing is we're trying to identify the resolution pathway for the complaint. Because there's such a huge range of complaints that we get from, I don't like the food that was served to me in the hospital, through to a complaint about a terrible adverse outcome as a result of a complication of surgery or, labour or whatever. So there's a very broad range. It's a great jurisdiction because there's such flexibility in it. So we get the complaint. There's a decision maker at triage. By decision maker, I mean that's somebody who's authorised under the statute to make a decision about the pathway. We're referring a lot of complaints back to providers to try and have the complaint resolved between the provider and the consumer.
We've noticed that.
Yeah.
Yeah.
And again, that's going to best meet the resolution needs, I think, of the consumer. We're getting quite a few complaints at the moment about access and delays.
Yes.
Providers are much better to manage those complaints because we can't get someone further up a waiting list, but we can have the provider communicate with the consumer about timeframes and expectations and safety netting advice. We have the opportunity to refer to, or the option to refer to the advocacy service, whom we contract, who can walk alongside the consumer to help them resolve the complaint directly with the provider. We also have a number of complaints where they're out of our jurisdiction or we think they're better dealt with by another agency like the Privacy Commissioner, so we refer those out. Sometimes we're satisfied that there's nothing to see here and we'll close immediately. The other emphasis in the triage process is that we're always looking to see if there are safety concerns that we need to escalate promptly to an agency for an immediate action. So that's another part of our triaging. Do you want me to keep going?
I think my observation is that, I do understand that, like everybody else, you've got severe resource constraints, you've had decrease in funding. But that's actually really helped, I think, in terms of, it seems to me, streamlining your processes, which is actually better for consumers and better for providers as well. So it means shorter time frames and, as you say, a lot of them are going back to the provider or to the advocates, and the advocates are great. So it's just, I think the resource constraint has really helped.
It's interesting you should say that, because I think that resources was a particular issue, but actually it was also complaints volume. Through COVID and that 21-22 year, 25% increase in the volume of complaints. It was a system already under pressure, and that was really extraordinary. And so it was about, it was about trying to manage complaints as they come in the front end, but then you've got this ageing cohort of complaints sitting in the system. So we have very much been focused not just on the impact of the resource constraints, but on the need to manage the cases on hand and the backlog, recognising that delay is not good for anyone. And if there's one thing that keeps me awake at night, it's delays in the system and the impacts that has on people.
Yeah, and I think we were recently listening to you, and you're saying that you have a 127% closure rate at the moment in the last year. Is that right? So you're actually getting through that backlog.
So we had very much a focus, as I said, on making sure that our resource was directed to those complaints that needed our involvement. We also had a restructure that helped alongside really streamlining processes because we needed to work on that backlog of complaints. It's been really successful. For the first time in many years, we're closing more complaints that we're receiving. That clearance rate has dropped slightly over the last year because, of course, it reflects also our ability to have got some of those older files out of the system. Yes, but we're still clearing more than we're receiving, and we're currently working under a 14% increase in year to date as well, but we're still maintaining that clearance rate. Yeah, so we're very happy with that.
It is, because I think there's nothing worse. I think in years gone by, and I think you're probably right, the 21-22 era was the peak of it, where, clinicians often felt that they send their response in and they heard nothing for a year and a half, and they thought, well, that's finished then, hasn't it? And then suddenly you get a letter a year and a half later. But that doesn't seem to be happening so much now. I don't know.
No, it's they're getting a response much quicker now. And I think that's really reassuring for them.
Very pleased to hear that, because I've also been, I am concerned about, communication, and we need to communicate well with the people that we're serving, consumers and providers. So glad to hear that you've noticed a difference.
It is. And one of the other things moving on from that is when the HDC does take the case, so it's not been referred back to a provider, and they send a letter out to the practice manager saying, we're asking for information. How often clinicians don't know the difference between that and opening an investigation. They often feel from that very first letter that they're being investigated. Can you just explain the difference between that? Because I think as soon as people get a letter from the HDC, they feel like they're under investigation.
Yes. So I was talking about the triage process and, sending things down the appropriate resolution pathways. For about maybe 20% of our cases, 20 to 30%, there is insufficient information on the face of the complaint to know what resolution pathway it should be sent down. So it then comes into our process as part of the ongoing preliminary assessment of the complaint, and at that point we're identifying information that we need to make a decision about how the complaint can be resolved. So we send out letters usually to the provider to respond to the complaint. We might seek additional information such as clinical notes, imaging. We will sometimes get information from other sources, like, for example, ACC. If there's a clinical question, we can get either an internal clinical steer or we seek external clinical advice. And then once that information is obtained, we do an evaluation of it and determine whether or not the matter can be closed without any further action, or whether the matter meets the threshold for progression to our investigations team, which is the part of our process where there's a formally notified investigation, and you will know it's a formal notification by reason of the format of the letter, at which point it's when an investigation is notified that we determine whether or not there's been a breach of the Code of Rights.
Yeah, I think doctors are often in such a panic when they see the HDC letterhead that they don't actually read the fine print of the letter very well, and they don't. But it's really important, because I think it's often something that we're clarifying with members when they phone us is, what does that letter actually say, and what part of the process are you in?
So to reassure members, what proportion of complaints go to investigation? Do you have that number?
Yeah, about 7 to 8%.
So it's tiny, really.
If you consider what we receive, about 3,600 complaints a year, the advocacy service receives about 2,600.
So less than HDC.
So
Yes.
there is less than the HDC. Ideally, although to be fair, they also manage about 20,000 contacts with people a year as well, where they're giving advice, about where somebody might go. So it's actually a small proportion of complaints that go through to that informal investigation phase, and an even much smaller proportion that ends up going through to our Director of Proceedings, less than 1%. And that's that very pointy end of our process where the breach of the code has been so significant that we've determined that the Director of Proceedings ought to consider whether or not there should be disciplinary and or action taken before the Human Rights Review Tribunal.
I think I looked at this, the number of cases where cases went to the HPDT. It's like there were 1 or 2 doctors. It really is very small. And I think that, the first thing people ask me often when they get a complaint is, am I going to get struck off?
Yeah.
And so I think it's reassuring to know that actually the risks of being referred to the DP is even the risk of an investigation is low.
And I heard that actually on your podcast, and that is quite startling to me, and I worry that is the reaction, because if you put it into perspective with reference to the data that we have, as you say, it's an incredibly small proportion of complaints get through to investigations, and then to DP, and I really want to try and reassure providers that our focus is about what can be done to make the system safer or of better quality for the future. I would like to think that we're part of the learning process, and as I said, completely acknowledge how confronting it is to receive a complaint. But we are trying very hard to bring a fair and independent approach to the complaints that we have, always with a view to identifying what can be done better. Sorry, I do need to add that, of course, there will be times where we think it's appropriate to hold providers to account for breaches of the code, because that is an important part of the process as well.
Yeah. It's interesting. I actually did some maths on the figures from your last presentation, and I worked out that if you get one of those gathering information letters, the chances of it actually culminating in a breach was around 6%. Whereas if you're actually being investigated and you've got one of the notification of investigation letters, the chances of being breached is 76%. So basically, if you've just got that first letter, it's still a very, very low chance that that's going to go on to a breach finding. So thank you for that. I think hopefully that will be some reassurance to clinicians to understand how that process works.
And I think I just wanted to add too that what I've seen is that when providers engage properly with the process, they don't just put their head in the sand and don't respond and miss all the deadlines, and they actually engage, then they learn from it. So I think that's really important for us when we're, as doctors, when we're responding to these complaints, is that it is confronting and stressful, but it's a learning process, and it is a process that you have to engage with. That's why it's so clear, and that will help you along the way.
And we help them. So if they contact us, we will walk them through those steps. And as it gets demystified, this process, I think most doctors, having taken advice, feel reassured, don't they?
They absolutely do.
Yeah.
Thanks. So what we were going to come to next was thinking about the causes of complaints that are most concerning to you currently, Morag. You know, have you got any particular theme of complaints that are worrying you at the moment?
Look, it would be fair to say, and I think you heard my talk earlier or last week, whilst it's not a huge proportion of our complaints, the issue of access and delay has been really noticeable in the last few years. And it's hard not to reflect from our perspective on the pressures in the system. And I think I've previously talked about also to different sort of conferences the fact that at some points we were also receiving a lot of complaints from providers who themselves were concerned about whether there was rights-based care being given to patients in the environments where they were observing that not happening. So, but of particular concern to me is the fact that we are seeing actual harm being caused to patients as a consequence of those pressures and resource constraints in the system. So absolutely concerned about that. And that's caused me to reflect too on how can the HDC influence and try to get improvement as well, rather than particularly traditional pathways that we use. Communication, you know, it even though it might not be the primary issue in a complaint, it features in nearly 70% of our complaints. So effective and compassionate communication and communication that enables people to understand what's happening in their healthcare journey is so critical. And actually, just picking up on the point before, when you talked about it being a learning process, one of the things about being responsive to complainants at that early stage, or patients who are raising concerns, is you prevent that escalation, don't you? You prevent that escalation to HDC. So communication is really critical. And I have definitely been really promoting the issue of informed consent. And the reason why I'm doing that, partly because that was the genesis of HDC. It was consent for women as part of that, unethical study back at National Women's all those years ago. But we're still seeing consent issues in 15 to 18% of our complaints. It doesn't move. It's a static percentage.
I think in the public system, you can see how the system itself makes it very hard to make sure that the consent process works well. And I think that, just speaking on behalf of clinicians, Chai, you might have an opinion here, that a lot of it isn't their fault so much as the system that they have to work within makes it challenging, doesn't it?
Yeah. So like you were talking about, the resource consents, the time pressures, all spill over into all aspects of care, so that you don't necessarily have access to the patients on the list to consent them properly. But I absolutely agree that if you are providing the care, then you need to be sure that the patient understands what care that they're receiving, and that's how they want to be looked after.
Yeah. And I couldn't agree more about the system as well. And so we have been looking at how systems support consent processes. But yes, ultimately, the provider who's doing the consent, or who's doing the procedure, is ultimately responsible for obtaining consent from the patient. And but I have definitely made comment in a number of the informed consent cases about the system not supporting a good consent process.
Yeah, and it's interesting to me that you say that 15 to 18% hasn't changed. even with all these changes?
One of the things that I'm really happy about is that by raising the issue of informed consent, we did a case involving consent trainees, and there was a lot of obviously responses to that particular opinion. But I kept raising consent, across the system, and Te Whatu Ora Health New Zealand is now going through a national informed consent project. When we did that decision, we actually did a bit of survey of what were then the 20 DHBs, different policies, different consent forms. It was remarkable. And so any opportunity to get more of a consensus about policy, forms, and any help we can offer in saying, well, here's the test and this is what the information you should be providing, the better.
Yeah, and I often think with consent, it's a very important part of the process. We all know it's fundamental to be able to provide care. But I think you often don't see the holes in your consent process until there's a problem, until there's an adverse event and the patient looks back and says, but I didn't know that. But you've followed the process that you've done before, but it's only when there's an adverse event that you notice the holes in your consent process, or that maybe there are areas that you haven't routinely talked to patients about. And then you stop to think, oh, maybe I do need to do that. Maybe there does need to be a change. And that is one of those benefits of learning, is that actually when something goes wrong, if you can look back and say, did we do that consent properly? And is there a way that we could do it better in future? Well, that's the bonus, isn't it?
Yeah, completely agree.
And I certainly think that providers change their practice. So if there's, and like you say, even if it hasn't been escalated to the level of the HDC, but there has been a complaint and a patient has said, I didn't know that you were going to do that as part of this procedure, and they were able to resolve it at that level. Most providers, and I know from our discussions within our departments, that they change their practice. They say, I now consent for that particular issue because of this patient saying to me, I didn't know you were going to do that.
Yeah, and it would be good if that was then spread throughout, as Morag says, everyone does it differently. Actually having some learning from each other is actually useful as well, isn't it?
That's one of the, we probably all have opinions about bringing together all the DHBs into one organisation, but that's got to be one of the bonuses of having Te Whatu Ora. As one organisation, there should be national standards across every region.
And also systems to alert people when they've found a hole, so that other people can know about that hole as well. Because I think that's, I think when it gets to the HDC and there's a breach finding, I think that does disseminate that information. But when it's resolved at a local level, the learning isn't spread necessarily, which would be something that would be useful anyway.
Yeah.
So we've been talking about the trends in the health environment kind of in that conversation about resource constraints, but I'm just wondering if you've noticed anything that's significantly impacting care provided in primary care and secondary care, changes in the way that we're providing medicine. I'm probably thinking telehealth clinics and single-use clinics and things. Has that changed what you see at the HDC?
Yeah, I should have mentioned primary care actually, because I think the pressures in the system and access issues and delays issues in primary care, actually what our complaints are telling us there about, I think, pressures in administrative systems. So it's referrals not being sent off or prescriptions not getting through to pharmacies. And a consumer contacting us saying, I can't get my medication, the script's not there. And so I think, and that to me demonstrates a lot that there are pressures within general practice just around some of those administrative tasks. Also, results management as well. That pressure of the inbox and the follow-up of abnormal test results or abnormal reports from a person who's been discharged from hospital. That's what we tend to see in primary care.
Yeah.
Yeah.
And with the telehealth clinics, has that affected you?
Yes, telehealth. We've it's quite interesting with emerging new models of care, because we don't obviously get a whole barrage of complaints immediately about that particular model of or provision of service, but we definitely have had complaints about telehealth. It does tend to be quite case specific, I guess. But when we did our review of our Act and Code, actually we did a bit of a sort of survey. It wasn't intended to be a detailed survey, but just really getting people's responses to the use of telehealth. There was general positive responses to telehealth because it's great for improving access, particularly for patients in different geographical or rural locations, or where they might not otherwise have access to general practitioners. But there were concerns expressed in some communities about the tools to allow them to access telehealth, in terms of internet provision, the actual hardware that's necessary to engage in telehealth service. In terms of the provision of the service itself, obviously it's subject to the code, so the code rights apply. I think that they tend to be single issue consultations, so sometimes holistic healthcare, or people express concerns about holistic healthcare, and I think for certain cohorts of patients, for example, the elderly, whilst it might be great for the particular problem that's being presented at, there might be issues about other health concerns that they might have. I think one of the other issues for practitioners is identifying the risk that's associated with telehealth, identifying that patient that actually is probably better to see face to face. So that's what the kind of thing we're seeing in the telehealth complaints.
What about the, Lucy mentioned what she termed the single use, or that we're talking about clinics that really have one focus. And do you have does that bring to mind these are the issues we see, or are you finding that actually there aren't?
We have not had, are you talking about things like the cannabis clinics? We've not had a huge number of complaints about those single use clinics or providers. Again, all I can say is that we would evaluate the care in accordance with code standards. Probably the concern that I have the most is those clinics that are being operated from overseas, and questions around whether registered health professionals in New Zealand are providing the care. We're working, whenever we get concerns raised with us about those kinds of things, we're working closely with, for example, MedSafe around the prescribing of medications. And of course, there are real concerns about follow-up for some of those clinics, ensuring that there is monitoring of whatever treatment is provided. Contraindications as well. Actually, that's something that also arises in telehealth, that a continuity of caring is sometimes a wee bit lost because medication might be prescribed, but there's a lack of awareness of conditions or other medications that might interact.
We just moving to a different topic. I just want to talk about expert opinions that you obtain. I assume, is there a process that you follow when you obtain an expert opinion in terms of who you choose to take that role?
We have a database of expert advisors or clinical advisors that we use, and it's grown over many years. And we do, assess that database and the suitability of experts on that database. And it used to be that we engage with colleges to get their recommendations for experts. That's less so now. If we find ourselves in difficulty trying to locate an expert, often other clinical advisors will help us find a suitable person. There is a process of onboarding an expert into HDC. We get a certificate of standing from the regulatory authority. There is guidance provided to the clinical advisor in terms of processes that they must follow, in particular issues around conflicts of interest. And you may have noticed recently, at least I hope you noticed, that we also developed a template for our expert advisors to use so that there's more consistency in how the expert advice is presented. And of course, we have our in-house clinical advisors who are available to the experts to have conversations with in terms of process. So it is. And whenever we're selecting a clinical advisor, it's peer for peer. So you're always trying to get somebody comparable to the practitioner that you're looking at in terms of the complaint. So, for example, if it's a rural GP, we would look to get a rural practitioner clinical advisor. That's one example. Conflicts of interest we always inquire about on any complaint. I have to say, New Zealand's a small place, and that makes it sometimes very, very, very difficult to find expert advisors. And we often go through many attempts to find an advisor who can ultimately give the advice.
We do find sometimes that some expert opinions to be of less quality than others, and which, is going to happen, of course. And so sometimes we obtain our own expert opinion for our member to present a different view. So how does the HDC view, how do you weigh up this expert versus that expert?
So I'm kind of almost speaking with a legal hat on here. It's an evaluation of evidence. And so with experts, there's quite granular analysis of it. For example, you want to be looking at the qualifications of the expert to make sure that they are qualified to provide the opinion. You also want to be really clear about what information was before the expert in order for them to have expressed an opinion. If I give an example, I've had a case recently where we had clinical advice. It was in a radiology case, and we also received some clinical advice from ACC, and there was a very close comparative analysis about what information was available to the advisor. And in that case, it was really important because what you want to do is guard against hindsight bias, and you want to be sure that what's before the expert was what the information that was before the clinician at the time they provided their advice, their diagnosis, their report. So it's really important to try and ensure.
You're trying to. It's hindsight bias is really hard in radiology, because if anyone you ask to review a radiology report,
they know something's up.
They know something's up, and also, a normal radiologist, I think sometimes they have kind of 7 minutes or something to do a CT scan or something really quick. But when you get something from saying, please, could you review this case? I don't think you're spending 7 minutes on it. I think you're spending a lot more. So I think it's very, very hard in radiology to actually completely eliminate that hindsight bias and the fact that someone knows they're being asked for a second opinion instantly will make them look at it in a different way, won't it?
We completely recognise that, and I think we try very hard to guard against hindsight bias in anything we do. It's like put yourself in the position of the clinician at the time, what was available to them. I completely agree with you, Lucy, about radiology. You've got a record, firstly.
Yeah.
An imaging record
of
what's happened. And blind reads are very hard to affect. If you're getting a letter from the HDC, can you do a blind read of this particular image? So we are very thoughtful about it. We're very mindful of it, and we try to be as fair as we can in the context of the information we have.
So over the last few years, you will have seen an awful lot of responses from clinicians. I'm interested in what you like to see in a response. What kind of approach can help resolve concerns? And then, on the other side, what kind of responses really make things worse for the clinicians?
It's actually a really good question. I want to start again by saying that it's really important for us to get provider responses. That we are independent. It's an impartial process in terms of looking at both sides, and we're inquisitorial. So we want to understand what happened. We want to try and find out what was said, what was done, what the impression was, and so the factual responses are really good. And if you've got, your clinical notes or corroboration in any other sense, then that's obviously really important for us to know. I think that you talked before, Lucy, I think about a clinician who had really reflected on what had happened and had taken steps to try and remediate or mitigate the harm or the event that had occurred. So a reflection is always on practice or steps taken to mitigate for the future is always really useful. What could have been done differently? Clarity is really helpful. Remember that for the most part, these responses are being assessed by non-clinicians, and sometimes those responses are shared with the consumer. So sort of plain English explanations, really useful. But obviously more clinical, if there's something clinical that needs to be expressed in clinical terms, then we can get clinical advice to help us understand the response. What is kind of less helpful in responses is overly defensive responses, responses that pathologise the complainant.
Oh, right.
In all honesty, sometimes you get them, and it's terrible when a person has raised a legitimate concern on the face of the complaint, and somehow that's put down to their personality structure or their mental health concerns or their anxiety, without reflection on actually this person might actually have a valid concern that needs an appropriate response. As I said, the best thing is to remain as factual as possible.
Yeah.
I recall one response where a defamation was also threatened in the context of response, and that's just going to be wholly unhelpful.
Mm-hmm.
Do you think you can tell when clinicians have involved their indemnifier and when they haven't?
Yes.
Does it make it better?
Yes, is the answer.
Do we make it better or worse? Yeah, that's a good question.
Hopefully we're helpful.
Oh, absolutely. I think that there's a clarity, and as I said, clarity is quite critical. Oh, can I also say context is really important too?
Yeah.
And I think understanding the context of the provision of the service is really important. When we were talking about resource constraints before, I want to reassure all the clinicians out there that whenever we receive a complaint, we always look at the context in which that service was provided. So if a person is fatigued as a consequence of being on duty for 72 hours, that's really valuable information for us to know. We do get, for example, ED weight numbers and things like that, which help us understand the pressures. More recently, I've dealt with an ophthalmology case where we had a lot of background about the efforts that clinicians had been made to raise concerns about the pressures within the service, all really helpful for us to bring a systems approach to the resolution of the complaint.
That's really useful. And we often, when clinicians are dealing with resource constraints, we often do say it's really good to highlight them in writing with your managers and with people, because actually if there is later a complaint, you can show that you've actually made those attempts. So it's nice to know. And the context is really important. I often think clinicians don't always understand that. And I often think it's at the very end of a phone call when a clinician's been telling you about a complaint and what's gone wrong. And then they say at the very end, oh, and actually this was a clinic where I was called in because someone else was sick and there were 30 patients there and I was trying, and none of that had been in the actual clinical context. And they tell you at the very end, the context which clearly outlines the huge resource constraints and the problem with it. So I do think it's important that clinicians realise that that is taken into account. So taking a step back from the actual response, do you, this is probably a question I don't know if you're going to want to answer, do you think there are attributes of certain clinicians that make them less likely to have complaints? If you were going to go and talk to a room of medical students or nursing students, what skills would you encourage them to develop to avoid HDC complaints in the future?
I mentioned before that communication features in 70% of our complaints. And I think being an effective communicator is really, really important. And I think being open to the fact that people are not always going to be happy about the service that you as a clinician provide, and that, if people have raised concerns with you, to address those at the time that they've been raised. So, and having good mechanisms then as an organisation too, for example, if you're a practice or a hospital, Health New Zealand, having good processes in place to manage that complaint. So I think communication and openness and engagement with the patient who's in partnership with the provision of their care, really.
So communication skills, I think that's probably what... Would we say the same? What do we think helps clinicians?
I would agree.
Absolutely.
We're going to be bringing out 2 podcasts, one for house officers in particular and one for, general clinicians around that very topic of communication. I think that the difference between us and AI, hopefully, is that we're human. And if we can relate to people as other human beings, as whole people, I think that we will all be better off.
Yeah, and I absolutely, in previous HDC decisions, which has been really helpful, you've pointed out that we're all human, and if the first interaction doesn't go well, there's always an opportunity to go back. And I think that that's really helpful for providers, that you're not expected to get it right one time. It's about the follow-up and the going back to talk to someone. And I think those decisions, and it's helpful in New Zealand that all those decisions are public and we can read them. And I think it really adds to the learning.
Yeah, I think that ability to go back is actually really interesting, because we all do have days where we aren't on our best game and we maybe don't do the consultations as well as we would like to. But if you can say, sorry, I probably didn't do that very well, can we start again? Reflecting, having enough understanding of yourself to know that it hasn't gone well, and maybe it's something to do with you that stopped it going well, not just blaming the patient when things don't go well, is actually really important, because, I think it does take self-reflection and a bit of humility to realise that we are human and we are going to have bad days.
Learning how to apologise appropriately and doing it in a timely manner and demonstrating empathy, I think, are really good soft skills that we all need.
Yeah. Well, I think we might finish there today, because I think that's been really interesting and really helpful, at least for us 3 and hopefully for our listeners as well. So thank you, Morag, for talking to us today, and thank you, Sam and Chow Yen, for coming along. And thank you to our listeners for listening to this podcast. We hope it's been helpful. We look forward to catching up with you in our next podcast, where we will be having Morag again. If you like the Medical Protection Podcast, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.